هنتكلم النهاردة على موضوع. هذا الموضوع تتخيل أنه مش موجود، ولكن هو موجود. لو بحثت عنه ستجده في 5% من الحالات. هذا الموضوع which is Hepatitis D virus, and this Hepatitis D virus, also called Delta virus. Hepatitis D virus infection cannot occur in the absence of hepatitis B virus. There should be hepatitis B, and there is no hepatitis D without hepatitis B, because hepatitis D require hepatitis B virus for its replication. Hepatitis D virus may cause acute and chronic hepatitis. There are two types: co-infection, that is to say B and D, or super-infection, that is to say infection with D on top of a previous chronic hepatitis B virus. When superinfection occurs, it is more severe disease than hepatitis B virus monoinfection. A vaccine against hepatitis B is the only method to prevent hepatitis D virus. As we see here, hepatitis D virus, inside the hepatitis C virus, it replicates in the viral B hepatitis. Therefore, it is distributed all over the world. Egypt, it is a low prevalence of hepatitis D virus. If you want to know what is the countries with high prevalence of viral D hepatitis, these countries: the Middle East, Mediterranean, Pakistan, Central and Northern Asia, Japan, Taiwan, Greenland, and parts of Africa, the Amazon basin, and certain areas of Pacific. You can say that around 5% of patients with hepatitis B virus co-infected with hepatitis D virus. The prevalence is low in North America, Northern Europe, South Africa, and Eastern Asia. Therefore, the mode of transmission of hepatitis D virus is the same as hepatitis B virus: percutaneous transmission, sexual transmission through contact with infected blood or blood products. Vertical transmission is possible but rare. Vaccination against hepatitis B virus prevents hepatitis D virus infection. Childhood immunization program for hepatitis B virus resulted in decline in hepatitis D incidence worldwide. What is the symptoms of hepatitis D virus infection? As I said before, it may be co-infection or superinfection. When the co-infection of hepatitis B virus and hepatitis D virus can lead to mild to, to severe or even fulminant hepatitis, but when there is recovery, it is usually complete and chronic hepatitis D is rare. Therefore, the co-infection may got a complete remission of the infection. Superinfection, and this is very important. Superinfection of hepatitis D virus on chronic hepatitis B carrier causes more severe hepatitis and faster progression to cirrhosis in 70 to 90% of patients than hepatitis B virus alone. Therefore, any patients with hepatitis B carrier, the care. If you got superinfection with D, therefore there is faster progression to cirrhosis and deterioration of your liver condition. People not immune to hepatitis B virus are at risk of hepatitis D virus. When got hepatitis D virus infection, also a risk of superinfection with D virus. Therefore, vaccination is very important and take care that all the children have successful vaccination. How, how we can know the hepatitis D virus infection? It is easy. You search for anti-HDV IgG and IgM. If you want to confirm, ask for the PCR. Three forms of hepatitis D virus infection: acute B and D co-infection, acute D superinfection, and this is the severe type of infection, or chronic hepatitis D virus. Therefore, co-infection of B and D, we find surface antigen and anti-HBC IgM positive, both positive, and anti-HDV IgM or total positive. This means co-infection. You can confirm by asking for the PCR of the serum for HDV RNA. This is, we find here the surface antigen and there is co-infection of B and D. If you want to confirm by PCR, and therefore the IgM is transient and the the total IgG going within 4 months to be very high. Therefore, we ask for both anti anti-delta IgM and anti-delta total. Therefore, we got the diagnosis and should have surface antigen and should have the core IgM of B. And therefore, this is it is not so severe, but may get complete cure from this infection. And therefore, if you wanted to be sure also, This is IgM anti-HBC, which is denoting acute hepatitis B virus infection. And this is IgM4D, it means acute D. And when it is transient, there is IgG, therefore this means the co-infection of B and D. Therefore, superinfection, and this is very important. Any patient find a sudden rise of transaminases and jaundice, take care, it may be superinfection with D virus. Superinfection of hepatitis D on chronic hepatitis B carrier, HBsAg positive, but take care, anti-HBC is negative. Anti-HBC IgM negative. Therefore, we find anti-HDV IgM positive, but it is transient. Therefore, we ask for both total IgM and IgG, and if you confirm by PCR. Therefore, if you repeat again, you find the jaundice, transaminases high in patient with chronic hepatitis B. He knows that he has hepatitis B infection. When he notices jaundice and the increased transaminases, you should ask for a HDV superinfection. How to know? The surface is positive of B, but IgM of B is negative. But the delta IgM positive, and it is transient IgG positive. Therefore, we ask for total. Therefore, it is increasing. If you want to confirm by PCR, you can notice here also, this is the IgM and of D, and this is the IgM IgG of D. We find rise of both in patients with surface antigen positive, but the core IgM is negative. Therefore, I think everything now is clear. But what is about the chronic hepatitis D infection? The high titer of anti-HDV IgG in chronic hepatitis D infection, it correlates well with ongoing hepatitis D virus replication. Therefore, you find the antibodies for the hepatitis D high. Therefore, both the hepatitis D antigen and PCR can be detected in serum and in liver tissue also. But it is easy to ask of the serum. This is summary of the diagnosis: acute hepatitis B and D co-infection, the surface antigen positive, the anti-HBC IgM positive, serum HDAG by ELISA, early and short-lived, frequency missed, not depend on. Serum PCR, early, transient, but last longer than the D, the antigen of D. Therefore, the antigen of D and the PCR, it is not necessary to ask for both may be positive, may be not early disappeared. But the anti-HDV total late low titer, increasing the titer. Therefore, the anti-HDV IgM transient and may be the only marker. Therefore, we depend on the anti-HDV total and anti-HDV IgM. It means acute B together with acute D co-infection and liver HDAG. It is not indicated. Therefore, with the co-infection of B and D, it is necessary to find the surface. It is necessary to find the IgM. It is necessary to find the delta IgG. It is and the delta IgM. This is the four which is important, and you can ask for PCR, but these are necessary. When acute HDV superinfection, the surface antigen positive, but take care, the core and IgM is negative, The HDAG early and transient as before, the PCR early and transient, but the anti-HDV total rapidly increasing, and this is very important. Also, the anti-HDV IgM rapidly increasing. The liver antigen is positive. Therefore, when there is acute HDV on top of chronic, you find the surface positive, not the core antigen. You find the anti-HDV IgM and total high. But when there is chronic hepatitis D infection, you find the surface positive, the IgM negative, the HDAV not detectable, PCR usually positive, and the anti-HDV total high titer. The IgM variable. The liver HDAG usually positive and may be negative. Therefore, for chronic hepatitis D infection, you should have the surface antigen positive, not the core IgM, and you should have the anti-HDV total high, but IgM it is variable. This is, I think, simplified and revised for the diagnosis. What is about HDV life cycle? Therefore, the HDV, once inside the hepatocyte, HDV RNA in the nucleus replicate at a very high level. The release is dependent on the presence of HBV, which provide the envelope due to dependence on the virus. As you find here, there is the HDV RNA cannot live by itself, but should be inside the hepatitis B virus, which help for replication. Therefore, the clinical sequelae of hepatitis D virus, it is variable. As we said before, it may be asymptomatic, or may be mild, moderate, or fulminant liver failure. What is the difference? Why it is asymptomatic? Why it is mild? Why it is moderate? Why it is fulminant? The severity of clinical course is influenced by several factors. may be related to different HDV genotype. Therefore, we relate it now to genotypes. The genotype 1, an increased risk of fulminant hepatitis, rapid progression to cirrhosis, increased risk of hepatocellular carcinoma, threefold, and mortality twofold. But genotype 2, less frequent association between fulminant hepatitis and progression to liver disease and chronic liver disease. The genotype 3, severe outbreaks of acute hepatitis D with high incidence of liver failure has been reported. Therefore, we can say now the genotype 1 is the serious one. What is about the clinical sequelae? As we said before, either co-infection or super-infection. Co-infection, acute hepatitis, may cause complete recovery or may lead to fulminant hepatitis or may lead to chronic hepatitis. But when there is super-infection, there is acute exacerbation. It leads to fulminant hepatitis or to chronic hepatitis. When there is chronic hepatitis, development of cirrhosis and hepatocellular carcinoma. Therefore, the chronic hepatitis, it is very important because it is the way to cirrhosis and it is the way to hepatocellular carcinoma. What is the treatment? Pegylated interferon for more than 1 year, optimal endpoint therapy, HDV RNA negative, most patients relapse after therapy, antiviral nucleotide analog for hepatitis B have no or limited effect on hepatitis B replication. New therapy such as prenylation inhibitors or HBV entry inhibitors may be promising. Why to treat and what is the aim of treatment? The primary endpoint is the suppression of HDV replication by normalization of ALT and amelioration of necroinflammation on liver biopsy and loss of detectable PCR in the serum and antigen in the liver, treatment should be administered for 1 year. The secondary endpoint is the eradication of hepatitis B virus infection with seroconversion from surface antigen to anti-HBs. Eradication of hepatitis B virus infection with development of anti-BS will protect the individual from reinfection with hepatitis B virus as well as hepatitis D virus, but the first endpoint there is liability of a recurrence of hepatitis D virus. Therefore, patients who have cleared HDV but who remain HBsAg positive are still at risk of reinfection with hepatitis D. What is about the prevention of hepatitis D virus infection? It requires the prevention of hepatitis D virus through because transmission through hepatitis B immunization. Therefore, when there is hepatitis B immunization, therefore, it is safety for protection from hepatitis D virus. Therefore, what is about liver transplantation? Hepatitis D virus are reinfection following liver transplantation. First, in 1995, annual report estimated that from 10 to 90% of around 100 liver transplantations performed annually in the United States for hepatitis B related liver failure are in, are in patients with concomitant hepatitis D virus infection. Reinfection with D alone not associated with recurrence of liver disease. Is very nice. When there is reinfection by D only, there is no disease. But when there is HBV reinfection, therefore there is hepatitis. Therefore, the infection with D and not B, there is no hepatitis. Three types of reinfection with hepatitis D virus following liver transplantation, either HDV reinfection without evidence of B infection, and this is good. HDV reinfection followed by HBV, it is the hepatitis, and simultaneous HDV and HBV reinfection. This is the cases, one by one. What is the HDV reinfection? Without hepatitis B virus reinfection. This is very good. Patient with isolated HDV reinfection. Serum transaminase is usually normal. There is no evidence of hepatitis on liver biopsy. Hepatitis D virus infection alone, little pathogenic effect on the liver. The diagnosis of hepatitis D reinfection alone is difficult. The detection of HDAG or HDV PCR in the liver. The clinical course of HDV reinfection is favorable. HDV infection provide a protective effect against hepatitis B virus infection, against hepatitis C virus infection. Therefore, the patients who are co-infected with hepatitis B, C, and D, the delta can protect from B and C. This is the case. Hepatitis D virus reinfection alone after liver transplantation. The patients who received immunoprophylactic and absence of surface antigen from the serum, the PCR detected in the serum, antigen in the graft for 15 months post-transplantation, serum ALT is normal. Graft histology remain normal. Therefore, liver biopsy and the enzymes is normal. Also, protect from B and protect from C reinfection. The hepatitis D virus and B virus reinfection, co-infection after transplantation, is accompanied by recurrent hepatitis. There is reappearance of surface antigen IgM and anti-HDV. Frequently, markers of B replication are negative, either spontaneously or after antiviral therapy. HDV consistently detected and more expression of antigen in the liver. If you want to see This is hepatitis D virus and hepatitis B virus reinfection after liver transplantation. We find chronic active hepatitis with B and D replication in the graft. Therefore, when there is HDV reinfection followed by HB reinfection, the return of HB infection as determined by the reappearance of surface antigen, recurrent of hepatitis, and progression to chronic liver disease. When there is chronic liver disease, there is progression to cirrhosis. When there is cirrhosis, progression to hepatocellular carcinoma. Therefore, hepatitis D virus is not directly cytopathic, and that hepatitis B is cofactor in the development of hepatitis. Therefore, HDV appear to inhibit HCV replication. It is good, and it lower the hepatitis B virus reinfection. Is good. Lower the risk of graft reinfection. Is good, and increases patient survival. There is benefits of the hepatitis D virus in transplanted graft. Higher survival rate and do not appear to develop fulminant hepatitis or fibrosing coloncytes. Therefore, the virus, D virus in the transplanted allograft is beneficial so long there is no hepatitis B superinfection. As we said before, it inhibits C, lower B, risk of graft rejection is low, increased survival, higher survival rate do not appear to develop fulminant hepatitis or fibrosing coloncytes. Is a case. This is the survival when there is D alone. This is a survival with B alone. But this is survival of B and D. Therefore, it is high survival with HDV alone and lower in HBV alone and intermediate of both. Therefore, what is the prevention of hepatitis D infection? But it is beneficial so long there is no B. Hepatitis D virus reinfection alone is abortive unless subsequently reinfection with B. A specific prophylactic for hepatitis D virus reinfection is not available. Currently, the combination of hepatitis B immunoglobulin and antiviral therapy is the most effective prophylactic for hepatitis B reinfection. Therefore, the prevention of hepatitis D virus infection, the most effective means of preventing hepatitis D virus reinfection is to prevent hepatitis B virus. Vaccination against hepatitis B virus with anti-HBs formation, HDV does not result in recurrent liver disease unless the allograft is simultaneously reinfected with B. Therefore, the treatment of hepatitis D reinfection, the specific treatment for hepatitis D reinfection, not necessary. Absence of hepatitis B virus reinfection is self-limited. Reduction of immunosuppression and corticosteroid withdrawal may be beneficial for viral B virus reinfection. Several antiviral compounds are being evaluated for the prevention of hepatitis B virus. Lamivudine is ineffective in suppressing hepatitis D virus and no data on the other analogs. Therefore, in conclusion, about 15 million people worldwide are chronically infected with hepatitis D and hepatitis B virus. Hepatitis D virus requires hepatitis B virus for its replication. The hepatitis D virus co-infection with hepatitis B virus or superinfection with hepatitis B virus, the virus is transmitted through contact with blood or other body fluids of an infected person. Vertical transmission for mother to child is rare. There is no effective antiviral treatment for hepatitis D virus. Hepatitis D virus infection can be prevented by vaccination. Therefore, there is a recommendation any patients with chronic hepatitis B virus find jaundice, high transaminases, take care to examine for hepatitis D virus. Any person should be vaccinated against hepatitis B virus to protect himself from hepatitis B. When you protect from hepatitis B, it is a protection from the hepatitis D. And thank you very much.